Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me for a rapidly descending dislocated IOL. So this patient saw their doctor about 3 weeks ago and was noticing that the lens was wobbling. There was some blurry vision at the time. And then several days ago, the patient noticed a dramatic loss of vision, saw their doctor again, and the lens was really very, very unstable. And so I got a call from the referring doctor stating that they were very worried that this lens was about to fall any minute, and asked if I could see the patient and take care of them. And so because of this, literally the next day, because this patient's coming from far away, I went ahead and removed this dislocating lens, removed the submarine ring as well. This patient also has a very small pupil, which again tends to be a sign that there's some zonulopathy. You're going to see I'm going to do my modified Yamane technique with the Sensor lens. Again, externalizing the leading haptic through a contralateral limbal incision, and you're going to see how I'm able to cannulate the haptic into the needle in this tiny pupil. So you can see this is the 3-piece lens. I don't even see a posterior capsule. I'm always surprised when I see these kind of cases how the lens actually stays where it's supposed to, despite there being no posterior capsule, no obvious capsular bag to be seen. So I go ahead and ink the tip of a 27 gauge cannula, and I'm marking on the right side and then the left side, making sure I'm 180 degrees apart. And this is the fixed caliper. I'm going to indent 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent. And I'm going to ink the indentation with the tip of that 27 gauge cannula. By doing it this way, you're able to achieve very discrete and precise marks. Same thing with the fixed caliper on the left side. Again, indenting 2.5 millimeters posterior in radial fashion and then 2 millimeters adjacent. I always dry the surface of the conjunctiva whenever I do this with a Wexel sponge. In order to get those discrete marks with the ink pen, you have to have a dry surface. And then using the cotton tip is much better at manipulating the eye. I go ahead and indent the sclera 4 millimeters posterior to the limbus. With the trocar, I'm going to tunnel about 3 millimeters, tunnel towards that mark, and then turning perpendicular, flush to the scleral surface, and then I enter. You saw that as I entered with the trocar blade, it caused the lens to wobble some. This is the 1 millimeter paracentesis blade. I'm going to make an incision contralateral to my main incision, and then adjacent to that for my AC maintainer. And then these incisions on the right and then left side are going to be the incisions to help me remove that descending lens. This is some intracameral epinephrine. And obviously, I'm putting epinephrine in to stabilize the pupil. But like I said before, this pupil begins to shrink throughout the case. And this is some dispersive viscoelastic to coat the corneal endothelium. And despite that, you can see I'm very careful watching the IOL as I put that dispersive viscoelastic in the eye. This is the 3.0 millimeter blade. Again, I'm entering it 90 degrees from those marks and 180 degrees away from my contralateral limbal incision. These are micro forceps. I grab the haptic contra-incisionally to me, but notice how I place vitrector through the trocar cannula in order to support the lens and protect it from falling. And then I grasp the optic with the right hand with forceps, and then very carefully I'm trying to prolapse the haptics into the anterior chamber. Once I have the haptics in the anterior chamber, then the lens is going to be in a more stable situation and reduced risk for falling into the vitreous space. You can see here as I tuck the trailing haptic, there's a large Sommerings ring as well. Now both haptics are in the anterior chamber now. Grasp the optic with the forceps, and now I'm going to try to figure out where I should cut to make explantation of these pieces the most efficient. And you can see you can use a scissor as a gripper as well, as you saw there. Go ahead and bisect the lens. And then switch it with forceps. Go ahead and grab the right piece. I go after the right piece because the haptic was not going to get in the way. With the left side piece, go ahead and make sure the haptic is not in the way. And then I pull the optic out with forceps. I go ahead and place the 22 gauge thin-walled AC maintainer in, and as I increase infusion pressure, I'm able to burp the Summerings rings out. You can see there's a little bit of vitreous at the end of this tag of Summerings ring. Go ahead and trim it with the scissors and using a Wexel sponge to be able to elevate that vitreous. Again, in my experience, the vitreous tends to be very liquefied, and this is part of the reason why the lens is dislocating. So again, in my experience, again, low risk for retinal complications. With all that manipulation, you can see now that the pupil is quite small. Go ahead and do a vitrectomy. And you can see here I've made 2 more incisions. And why is that? Because I'm in preparation for placing iris hooks as needed for my leading haptic. So I'm confident about my trailing haptic, but with the leading haptic, I'm going to need better view. So this is a 25 gauge needle. I have the bevel facing to the right. That's for externalizing the leading haptic. And this is the right side 30 gauge thin walled needle. I bend it 9 millimeters from the tip and have the bevel facing towards me. And then on the left side, this is a 30 gauge thin walled needle, and I'm having it bent at the hub and facing away from me. This is the cartridge for the sensor lens. I put some cohesive viscoelastic on the cartridge. And then I'm placing the lens in proper orientation. You have a picture on the wing there, making sure it's seated. Before I fold the wings, make sure the leading haptic comes out through the barrel and the trailing haptic comes out from the back end, and the lens bends concavely. Placing the cartridge into the injector, making sure the leading haptic is swept up outside of the barrel. There you go, just like that. Advance the plunger and push the lens forward. And then I'm ready to externalize the leading haptic through the contralateral limbal incision. So this is a 25 gauge needle. Again, the bevel is facing to the right. I place the injector through the main incision. My technician advances the lens. Once the leading haptic comes out, I align the leading haptic to the needle, making sure it's docked on the haptic of the bevel of the needle. And as the lens comes out, unfortunately, in this case, the lens flips over. And so that was probably my fault. I wasn't mindful of rotating the barrel with my wrist as the lens was coming out. But that's okay. The lens is completely in the anterior chamber. And I'm going to grab the optic with forceps, push down. And as I push down, I turn it around 180 degrees. And so now it's in the proper orientation. Push some dispersive viscoelastic to push the lens back and to coat the corneal endothelium. You can see the pupil is really small, and as I'm doing this, you can see there's now iris prolapse. And so this is a small pupil. There's clearly some IFIS, but I decompress the chamber, burp the viscoelastic out, and then the pupil goes back in. So I have to be mindful throughout the case that this can happen again. This is the 30 gauge thin-walled needle to hold on the right side. I'm making sure that the mark is perpendicular to the limbus. I'm grabbing the incision with my forceps. I stab at the first mark. Turn on infusion now. Here we go, turn on infusion, tunnel, 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 and go to that second mark and I dive down. So I tunnel 2 millimeters, but you can see here I'm getting iris prolapse once again. So I turn off the water. Again, remember when I'm tunneling, I have to have high pressure. So infusion is on as I'm tunneling, and then I dove down and then iris came forward. But now I can turn off the irrigation. So turn off infusion, and now I'm burping and burping and burping, decompressing the chamber, and now the iris goes back in. Again, at this step, I don't need to have a firm globe, only when I'm tunneling the needle through the sclera. Pushing some dispersive viscoelastic to push the iris back now, and then using the microforceps, non-toothed forceps, very carefully grasp the sensor trailing haptic, holding it perpendicular, docking the haptic on the bevel of the needle, and it goes right in, like butter. So again, for my technique, even with a small pupil, the trailing haptic is no problem. Why? Because the optic is pushed away and the leading haptic is outside the eye. And that is why doing the trailing haptic with this technique is really very easy. Disengage the needle from the syringe and then laying it down. And then internalizing the leading haptic with microforceps. And so because now my second haptic is actually going to be the leading haptic, not the other way around. Remember the way Yamane does it, Shin Yamane does the leading haptic first and then the trailing haptic. That's why the trailing haptic is so much more difficult. But on top of that, it's subincisional. It makes it really hard for those, especially if you don't really have a lot of experience doing this. But since I go after the trailing haptic first, then now, because of the push-pull and tug-of-war effect of that lens-needle complex, I have to put hooks in to retract the iris contra-incisionally so that I can cannulate the leading haptic through the left side needle. So I'm grabbing the incision, and I want to make sure again that my mark and the direction is going to be perpendicular. I stab and I tunnel 2 millimeters to that other mark, and then I dive down. As I did this, of course, you see there's more iris prolapse. So again, while I'm tunneling, infusion is on. That's why the iris came out. Once I've stabbed through, I can turn off infusion, and then I'm burping the iris back in. Alternatively, I could have put a subincisional iris hook, but again, luckily I didn't have really terrible iris prolapse, and I was able to just burp it back, and it didn't really cause any severe iris damage here. So I go ahead and grab the leading haptic, and because I've retracted the iris very nicely, I'm able to dock the haptic on the bevel of the needle. I have good visualization. And remember this, you're going to turn the needle towards a haptic, not the other way around. The primary mistake that a lot of people make is they try to manipulate the haptic towards the needle. That makes no sense because the haptic is made of plastic and the needle is metal. So move the metal needle towards the haptic. That makes it a lot easier. And you saw that in this case. I turn that left side needle to face the leading haptic, dock the haptic on the bevel needle, and it went right in. So I go ahead and pull the left side needle out towards me. And as I do that, I make sure I have the microforceps ready to grasp it and avoiding too much externalization of the haptic. And then I'm drying the surface because remember the water will interfere with cauterization. And I get a nice tiny bulb. But it wasn't quite a symmetrical bulb, and that's because there's still some water. So I go in with a Wexel sponge, dry it completely, and then I do it again. So there's a nice bulb now, nice and even bulb. Do the same thing on the right side, pulling the needle away from me because that's the direction that the needle came from. As I'm pulling it away, I grasp the haptic and then just make sure that I push down, make sure the haptic doesn't come out too much. And then I remove the needle, holding the haptic with the forceps, and again, drying the surface completely. By drying the surface completely, there won't be any water, and if there's no water, it will not interfere with cauterization. And then I go ahead and cauterize to get a nice bulb. You can see, again, flat profile of the haptics means great scleral support, nice scleral shelf, therefore less likely to lead to a flagpole sign and less likely to lead to a tilted optic or a badly positioned lens. Pulling the stopper back using a two-handed technique, turning the iris hook sideways so I can take the iris hook out. And then doing the same thing on the second hook. So again, I did not need the iris retractors for the trailing haptic because I was able to move the optic away from me because I've externalized the leading haptic, which allows me excellent access to that trailing haptic. But I did have to do it for the leading haptic. Now I go ahead and close the main incision with a tono nylon suture. And I always like to do that because remember, I've dealt with vitreous and therefore there's possibility that vitreous may try to come to the wound. And so this is my surgical PI. I'm going in through a contralateral incision, pointing the tip down, and I'm changing my setting. This is a low cut rate setting, high vacuum, low aspiration because you just want to grab it. And once you grab it, you want to get that high vacuum. You don't want to suck too hard. And then you get a nice, small, discreet, well-located PI. Again, you don't want to go all the way to the very edge because you might eat the ciliary body and cause hemorrhage. Go ahead and do some more vitrectomy through the pars plana trocar, and then do some more through a limbal incision. Pulsing some BSS through a paracentesis incision, and again, this is just to help get some of that dispersive viscoelastic off the cornea. You can see how floppy this iris is and how small the pupil is. Go ahead and grab the trocar, and as I'm pulling it out, I turn off the infusion and then tamponade the sclerotomy with the cotton tip. Go ahead and hydrate the incisions, and that's the end of the case. So again, this is a rapidly dislocating three-piece lens. I was able to retrieve it by using a two-handed microforceps technique, prolapsing the lens up into the anterior chamber, cutting the lens completely in half. Using the thin-walled 22-gauge AC maintainer, I was able to employ high infusion pressure, and then I burped out the Summerings ring one piece at a time. But as I was doing this, I saw the pupil shrink. But again, it doesn't matter for the trailing haptic because I'm able to externalize the leading haptic, which moves the optic away from me. I was able to cannulate that right side needle with the trailing haptic very easily without any trouble. But then I made extra stab incisions to retract the iris in the area of the leading haptic. I was able to tunnel the left side needle through the sclera, and then because I retracted the iris, I was able to very easily dock the haptic on the bevel of the needle of the leading haptic. And remember, you want to turn the needle towards the haptic, not the other way around. Dock the haptic on a bevel needle, and then it slid right in. I was able to externalize the needle and then grasping the haptic with forceps. But remember, drying the surface of the eye before I cauterize, doing the same thing on the other side. And this patient did very well. No problems as far as executing the technique, again, with this Sensar lens and a small pupil. And it all boils down to paying attention to the minor details, making sure you're aligning the needle and the haptic to one another, docking the haptic on the bevel of the needle, which all is predicated upon how you bend the needle. And then being mindful of turning the needle towards the haptic and not the other way around. So I hope this was helpful to you, and I thank you for your attention.